Today I'll talk about the fetal circulations and Doppler, which will, inshallah, will answer the MCQ questions that I posted earlier. So let's begin with the uterine artery first, because as we know, at 16 to 18 weeks, there will be a complete of the second wave of trophoblastic invasions. So what happened is that in a normal non-pregnant lady, the uterine artery is something that we can measure, and it's represent the spiral artery. So in non-pregnant lady, usually the uterine artery Doppler will be very high systolic and with low and diastolic. So there will be a notching here. But usually, after the modulations of the spiral artery, when we know we have the angiogenic factor, which is good for pregnancy, and we have anti-angiogenic. This is also something that we can measure to predict preeclampsia. So anti-angiogenic factor like VEGF and say PLGF, vascular endothelial growth factor and placenta growth factor will be increased in normal conditions, and anti-angiogenic factor will be reduced, like S-fleet 1, SNG. Okay, so this is a normal conditions, but if it's a preeclampsia, then it will be on the other way around. So in the normal pregnant, there will be modulations of the spiral artery, whereby there will be very high resistance vessels, the spiral artery, and vasoconstriction. But since we have this modulation, so in a normal condition, the artery will become less resistant, and there will be a vasodilatations, so that it can improve the blood flow here. And the uterine artery supplies about 90% of the flows to the placenta. So in the normal pregnancy, what will happen will be the uterine artery will look something like this. So you will have the systolic, peak systolic velocity, and you have the diastolic here, peak and diastolic. So now we can calculate the PI and RI. So usually, RI is to show the resistance of the impedance in the blood vessels. So we calculate by the peak systolic volume minus the end diastolic divided by the systolic. So we can get the resistance in the vessel itself. The PI is a little bit different, where we want to see the pulsatility index of the vessels. So it's the systolic minus the diastolic divided by the mean, or the velocity in the mean during each contractility. So if let's say during non-pregnant, we'll see, and the PI and RI usually in the linear graph. So as the resistance high, the pulsatility index also will be increased, and this will show the vessel is having a high resistance and vasoconstriction. So what happened is that, so during pregnancy, after the second trophoblastic invasions and these arterial modulations, so there will be a flow to the fetus. Okay, so allow me to sketch the fetus first, but just for the sake of memorizing all these soft markers in the ultrasound. But this topic is only relevant for a normal baby. Not if it's a syndromic fetus, then it's not of the discussion. because they will have a very early abnormal circulations, we anticipate the baby not to have a normal. So there will be a hypothyroidism with low set ear and flat nasal bridge with cleft lips and web neck here. And there will be a trisomy fingers, clench fist, and AC is small with a rocker bottom feet. So I'm gonna show the circulation first, and we're gonna zooming in these circulations here. Zooming in. So as we know, there will be a blood from this placenta, and the maternal and the fetal blood is not mixed. The circulation is not mixed. There will be a barrier, and we have a different kind of hemoglobin for the fetus and also the adult, with fetus with a higher affinity to the oxygen. So, and the blood, oxygenated blood, will be transferred from the placenta to the fetus via the umbilical vein, goes to the ductus venosus, bypass the portal system, and goes into the fetal circulations, which will be the highlights of today's video. So as we know, there will be a ductus venosus from the umbilical, so it bypasses the normal portal systems. It will get into the IVCs, so the IVC will get into the right atrium. Sorry, the IVCs and this superior vena cava will get into the right atrium. So we have something like this here. And this will goes to the lung. This will be the arteria venosus. So we have the septum here. This is the right ventricle. This is the valve. Okay. And here will be a aorta to the peripheral circulation. So aortic arch. This might not be the nicest heart that you can see. Oh, there's no septum here. There's no ventricoseptal effects. So basically, the oxygenated blood pass through the ductus venosus, gets into the IVCs, and this superior vena cava goes into the right atrium, and we have the foramen ovale here. So by right, the blood will goes either to the right ventricle, or through the foramen ovale, goes to the left atrium, and gets into the left ventricle and goes to the aorta. However, since there is oxygenated blood here, and there is a foramen ovale, there will be mixed of blood. And in fact, there will be mix of blood since here, because this is the oxygenated, this is the deoxygenated before it's entered the right atria. So the right ventricle, so there will be two fetal circulations here. First, the foramen ovale. Second one is the ductus arteriosus here. Ductus arteriosus, basically from right ventricle, it will goes into the pulmonary artery, and since the pressure in the lung is high, because of the lung is not yet functioning, the resistance is very high, so it goes straight away into the aorta, the arch. So it goes into the aorta and goes to the peripheral. So here we have here now the umbilical artery, which will goes back to the placenta, carrying the deoxygenated blood. Okay, so it goes back here, the umbilical artery. So in fetal circulations, basically what maintain the ductus arteriosus to be high is the prostaglandin E1 and PGE2, and PGE2 is the most the active prostaglandin that helps the patency. This actually produced by the placenta and also the cells located at the ductus venosus itself. So it was produced by the ductus venosus itself. So this will keep the patency in utero. What happened is that when the baby delivered, there will be and the placenta attached from the fetus, so they will be reduced in the prostaglandin. So first mechanism is the placenta detached, so they will be reduced in the prostaglandin, and the baby starts to cry, so the increase of the oxygenations in the lung cause the reduce in the resistance because the lungs expand now, so the resistance becomes low. So when the PO2 arterial increase, then the resistance and also pressure in the ductus lumen become low, then there will be a closure of this of the ductus arteriosus. And the third is what the bradykinin. Once the lungs is expand, so it will produce the bradykinin. So bradykinin also promotes the closure of the ductus venosus, and usually ductus venosus will close on the first or second day of life. And there is an MCQ about the closure. It's quite obvious if it's a pram baby, so the closure will be by the givens of the NSAIDs, which is to reduce the prostaglandin. And if it's a term baby, then there will be needs of the surgical closure. Okay, well, the foramen ovale usually will about 75% will close right after birth, and another 30% will remain about 6 months after the delivery, after birth, but we still call it as the patent foramen ovale. And basically the foramen ovale, there is no much issue with the foramen ovale if it remains patent, because there will be only a mixture of the oxygenated blood and deoxygenated blood. But the main issue with the foramen ovale is the clots, because clots is quite frequently formed in the vein as compared to the artery. So because the vein has low velocity as compared to the artery and pressure, so it's prone to have clots. And usually the treatment for patent foramen ovale is the anticoagulant. Okay, so actually I would like to highlight on the Doppler itself. So as we know, this will be a good predictive value, especially in the patients with history of preeclampsia, history of IUGR babies, and also for those who underwent the IVF. So usually in the MCQ, we anticipate to have this kind of pattern, especially at the early pregnancy, when this modulation is not complete. So the notching of the in the uterine artery Doppler is normal, especially before 20 weeks. But after 20 weeks, usually when it's already complete, the modulations, the arterial modulations on the spiral artery, usually there will be change in the Doppler. So for the early stage of the pregnancy, usually we take the centile, the PI. There will be a graph, so we look at how many centile. If it's more than 95 centile, then it will have a very good negative predictive value. So 95 shows a bad prognosis. So the women will have a higher risk of having preeclampsia, and treatment need to be initiated. If it's low, then the probability of getting a preeclampsia is very, very low. Okay, so now we move to the umbilical artery. when we talk about the umbilical artery, we are talking about the deoxygenated blood from the fetus to the placenta. So we are talking about actually the pressure in the fetus. Now we know that in preeclampsia, when there is a poor second wave trophoblastic invasions and the endothelial dysfunctions, there will be high resistance and also high pressure in the maternal circulation. Due to this stressor, the fetal also develop the same reactions with the higher resistance. So that is why at the early of, if it's a normal pregnancy, you'll see the Doppler of the umbilical artery will look something like this. So this is the umbilical artery in a normal condition. Say for example here is 4, the peak systolic volume, and here is 2. So the ratio now is 2:1. So it's a normal SD ratio. And what about the PI? The PI is the RI. The RI is 4 minus 2 divided by the systolic 4. So you get 0.5, which is very good. A normal value for the umbilical artery at the second trimester is about 1.5 to 2. Is considered to be normal. And on the third trimester, it will be 1 to 1.5. So, and the PI, this is the value for RI, the value for the PI. For the RI, basically it's 0.7, somewhere there. RI is 0.7. But anyhow, you can always look at the graph, which available in the scan machine. So for the PI for these patients, if it's normal, then 4 minus 2 divided by 2, right? So it's become 1 now. So in the abnormal condition or IUGR or PE, when there is a placental insufficiency causing a high resistance in the fetus as well, so there will be high peak